We'll move on to last presentation, which again will be a CTO challenging case by Dr. Sherif Elbiltagui from Egypt.
Bismillah ar-Rahman ar-Rahim, Mr. Chairman, my professors, dear colleagues. My case actually is not very challenging, but it is a complex, lengthy case, which I think can deliver some messages. It's, you know, that the CTO is on the top of the list of complex PCI lesion subsets, which also includes multi-vessel disease, unprotected left main, osteal lesions, and bifurcation lesions. But when you have all these subsets in one single case, you expect that it is a really complex and lengthy. So for a relatively young guy, pre-diabetic hyperlipidemic, with a stable angina for some time, progressing into crescendo angina in the last few months with a good ejection fraction. As you see, it's an osteal LED CTO with some poor antegrade flow, probably through channels or maybe bridge collaterals. The obtuse margin also has a moderate but looks not significant lesion. The RCA as well has a diffuse disease with a significant proximal lesion. I actually offered for him cabbage for the first choice, but the patient refused strongly, and he came back after a few days for a multi-vessel PCI. I started with the easier, the RCA, it's fixed easily, and then optimization. And then you can see it's a good septals to the LED, encouraging you to start as a primary retrograde approach, which is very appealing in osteal lesion, often, osteal CTO, I mean. But anyway, I thought maybe I'll give a try for the antegrade approach first. So I started with the fielder, but of course, I got a tough time to indulge it into the proximal cap. As you see, it's always prolapsing in the CX. So I got help of one of the supercross microcasters, and actually it helped a lot. So the wire can negotiate the proximal cap, as you see here, avoiding the prolapse, and I could advance, but to the diagonal, not to the LED, but the microcaster couldn't actually advance the osteal proximal cap. So I used the balloon, and after ballooning proximally, I could get a rather a good flow, but to the diagonal, not to the LED. And you can appreciate another total occlusion with an ambiguous stump in the mid LED. So now you can again think of retrograde with such good septals, but anyway, I have the fielder on board. I thought maybe give it a short try. I picked a turn-back microcaster, and the fielder actually could negotiate the ambiguous stump in the mid-LED, advanced easily, as you see, but not anymore in the mid-LED. So I got help of the second, Gaia second, advances the microcaster distally, and then the Gaia second could do it, exchange to BMW, and while I'm trapping the microcaster out, and shortly after that I was busy in pre-dilating proximally, the patient has severe sudden, unexpected chest pain. He was screaming, actually. And we didn't know the reason at that time, but an angio showed a very nasty spiral dissection of the obtuse margin. Of course, it was without a wire. I didn't know the reason, actually, but probably from accidental advancing of the trapping balloon while I was removing my microcaster. Here, actually, I was really lucky, as the run-through probably could negotiate through this long spiral dissection in a few minutes while the patient was in real pain. After that, pre-dilatation, then a bailout long stenting, and of course I did optimize it at that time in order to get back to my original procedure, the CTO, where after opening the LED, you have a very nasty bifurcating lesion with a lot of dissection, especially in the diagonal. So obviously, I have to stent the diagonal first. So I used the mini crush, long stent in the diagonal, then good crushing, and then I continue by stenting the proximal LED, and of course I used the crossover from the left main to the proximal LED covering the ostium. And then I discovered that there is a residual dissection in the mid LED. I hoped that I used Dr. Colombo technique here. If I have a pressure wire, maybe I would not stent this. I hate to stent the distally, but I tried to stent avoiding the distal portion. And then I got back to my bifurcation to optimize it by using a pot, and then recrossing. And I remind you that recrossing in a mini crush should be a proximal or a mid recrossing. Avoid distal recrossing in contrast to other techniques. And then opening the struts as usual. Don't forget to optimize your stents, LED, diagonal, before ending this bifurcation with a kissing. And then more optimization proximally in the proximal stent. And then lastly, I have to deal with the distal left main bifurcation. Here is the pot with the 4.5 balloon. And then now recrossing here, because I will do a tap, this will be as usual, distal recrossing. And then, as usual, tap to the CX, and then this kissing balloon, and then final pot with a 5mm balloon. So I was lucky, actually, after a lot of work, to end with such a result, acceptable result here, and also in the lateral view. So it was a lengthy procedure, actually. 3 hours, 45 minutes, more than 480 milliliter contrast. Yes, I did achieve complete revascularization with the two CTOs, ostial LED and mid LED, two bifurcating lesions, one treated with a mini crush and the other with the distal left main with a tap. And of course, don't forget the acute closure in the middle of the procedure, treated with a bailout stenting. So, Mr. Chairman, my message in this case is that CTO PCI per se is often a long, complex procedure. But when combined with a multi-vessel disease and multiple technically demanding lesions, as left main, ostial, and bifurcating lesion, it is even more complex and very exhausting very exhausting to the operator and the cath lab team. So it's crucial to remain focused and to complete all steps for each lesion, including final optimization. One should be ready to deal with any complication and different interventional CTO as well as non-CTO techniques. And I remember this lovely slides from Manus Brilakis, which says that there are many reasons why CTO PCI will make you a better intervention cardiologist. Thank you very much.
Thank you very much.